So today's topic is uterine inversion. So what is inversion? It is rare but life-threatening complication of third stage of labor. Approximately occurs in 1 in 20,000 deliveries. The obstetric inversion is almost always an acute and usually complete. So definition: when uterus turns inside out, it is called as uterine inversion. Inversion of uterus means uterus is turned inside out partially or completely. It is the folding of the fundus into the uterine cavity in varying degrees. It is called uterine inversion. Next, three types. According to the types, degrees and timing of the event, the classification of uterine inversion is. So, if it is the normal uterus, the position is like this. But in case of inversion of the uterus, the retroverted and retroflexed uterus are seen here, which are prone to inversion. First degree, second degree, third degree, and fourth degree. So in first degree, uterus is partially turned out. Second degree, the fundus has passed through the cervix but not outside the vagina. Third degree, the fundus is collapsed outside the vagina. Fourth degree, the uterus, cervix, and vagina are completely turned inside out and are visible. So we have to see the degrees of collapse. First degree, second degree, third degree, and fourth degree. So universally, first degree is incomplete inversion, second degree is complete inversion in the vagina, third degree is complete inversion outside the vagina. So first degree, second degree, third degree, these are the most followed up classification. So if it is in acute, subacute and chronic, acute it occurs within 24 hours of delivery, subacute it presents between 24 hours and 4 weeks of delivery, and chronic it presents beyond 4 weeks of delivery or in non-pregnant stage. So causes are excessive contraction, excessive fundal pressure with placenta, accreta, congenital predisposition where it is either retroflexed acutely, and fundal implantation of the placenta, and spontaneous or iatrogenic causes. So mostly after the delivery of the fetus, excessive contraction when we are delivering the placenta or unseparated placenta with placenta, accreta, increta, percreta, and excessive fundal pressure when uterus is poorly contracted, all this will cause inversion of uterus. So spontaneously also occurs when there is short umbilical cord or when it is shortened by being wrapped along with the fetal body. So sudden rise in intra-abdominal pressure due to maternal coughing or vomiting also will lead to inversion of uterus. So morbid adherence of the fundally implanted placenta also will cause inversion of the uterus. So connective tissue disorders like Marfan syndrome will also lead to inversion of the uterus. So how to prevent it? Mainly if you do mismanagement of third stage of labor, when you are pulling the cord when the uterus is atonic combined with fundal pressure, it leads to uterine inversion. That is nothing but Creedy's expression, that is pulling the cord when the uterus is relaxed, and faulty technique of manual removal of the placenta will lead to uterine inversion. So while separating the retained placenta from the wall of the portion where it is attached, if it is adherent and if it is uterus is atonic, it will also lead to inversion of the uterus. So main signs and symptoms are hemorrhage. The uterine inversion will also present with hemorrhage. It is a part of third stage complication, and severe abdominal pain in third stage of labor, and hypotension. Patient will be in shock out of proportion to the blood loss, mainly neurogenic due to the uterine inversion with increased vagal tone, and fundus is not palpable abdominal. When you go and see the patient, you will see the mass protruding through the vagina, and at the same time the uterine fundus is not palpable. And sudden cardiovascular collapse. Patient will be having severe pain with in shock. and lump in the vagina. You will see a mass protruding through the vagina. Abdominal tenderness will be present and absence of uterine fundus on abdominal examination. So shock is initial out of proportion with the amount of blood loss, but woman becomes sweaty with bradycardia and profound hypotension, and rarely cardiac arrest may occur due to the vasovagal syncopal attack. So there is a marked hemorrhage and a hypovolemic shock. Differential diagnosis of inversion of uterus are mainly uterine rupture, prolapse of the uterine tumors if they are present like submucous fibroids, large endometrial polyp, passage of the substantiate lobe of the placenta. We will think it is called as inversion of uterus. So mainly uterine inversion, when it occurs, you have to resuscitate the patient, start IV fluids, start airway, and re-establish the oxygen status, that is ABC, airway breathing and circulation should be established by giving IV fluids, oxygen inhalation, and replacement of blood. So when the basic procedures are done, you have to go for immediate replacement of the uterus, that is uterine inversion should be corrected. For that, what we have to do, first you remove the placenta if the placenta is adherent and start oxytocin 40 units in 500 ml of normal saline. So if the uterus is not able to be reduced, you have to try manual reduction. Apply pressure to the dependent part of the uterus with the fist and simultaneous pressing with the other hand on the abdomen. You have to invert the uterus and replace it back. Otherwise, you have to go for various methods after stabilizing the patient. They are called as fossil ones, hydrostatic methods, where the dependent part is replaced into the vagina using 5 liters of solution which is deposited into the posterior fornix with a continuous flow, where you have to assist creating watertight seal so that the uterus is replaced into its original position. So this is Ocillon's hydrostatic by using a 5 liters of solution which will cause replacement of the uterus. Other work is team work. That means resuscitation, uterine repositioning simultaneously by using Ocillon's hydrostatic method or manually. So postpartum hemorrhage drill is important to be taken. The quickest way to treat the neurogenic shock is to replace the uterus. So patient is having both hemorrhagic shock and neurogenic shock. So we have to teach a postpartum hemorrhage drill to all the team members, especially the postgraduates and the assistants in the department. So when there is acute inversion of the uterus, if before the shock develops, what to do, and after the shock develops, what to do. Mainly before the shock develops, we have to immediate manual replacement has to be done. But if the patient is in shock, first we have to resuscitate the patient and immediate steps of management of shock to be done. And principle is the part of the uterus which has come down last should go back first. Here what we have to do, first the diagnosis made immediately after the inversion of uterus has occurred, and the degree of relaxation of the myometrium and cervix has to be assessed, whether you can invert it immediately. And if they are relaxed, it will allow the uterine replacement easily. So the gloved hand is lubricated with betadine or antiseptic cream and placed inside the vagina, and the uterine fundus with or without the attached placenta is cupped in the palm of the hand from above, and the fingers and thumb of the hand are extended to identify the margins of the cervix. So we have to hold it like this. The whole uterus is lifted upwards towards and beyond the umbilicus, and additional pressure is exerted with the fingertip systematically and sequentially to push and squeeze the uterine wall back through the cervix. So you have to feel the fundus and push it properly into the abdominal cavity. So sustain pressure for 3 to 5 minutes to achieve complete replacement with counter support from above the abdomen should be done. Once the fundus has been replaced, keep the hand in the uterus, where rapid infusion of oxytocin is going to contract the uterus, and initially bimanual compression aids in the control of further hemorrhage and until uterine tone is recovered. So When the uterus is contracting, the hand is slowly withdrawn, and if placenta is attached, it is to be removed only after the uterus becomes contracted. And if partially it is detached, it should be peeled out before the replacement of the uterus.